but she couldn't even really turn over in bed. She was able to get up with PT, still having some pain, but she was able to stand up the next day. And then this is her 6 weeks later with no pain. This is a 82-year-old gentleman with intractable pain, just screaming, moaning the whole time, can't get comfortable. He asked if there was anything I could do. There was a smaller surgery. I thought about IlluminOss. This is post-op immediately. The kicker, though, is that he woke up and had no pain immediately. He says, no, the moment I woke up, I had no pain anymore, going from just excruciating and not being able to move to no pain, just getting him to the point that he was healed and could get a pretty reproducible procedure. But he's now a year out. He's had still no pain. He hadn't progressed to a total hip. In my hands, I've just had a better luck with IlluminOss over Curvifix.
Typical fracture patient, 77-year-old woman. She falls and has hip pain. She's got some medical issues, very painful. This screw has really no purchase in anything. I'm like, this bone is really pretty shitty. I can put an intramedullary IlluminOss. All of these screws docking in to the IlluminOss balloon. 6-week follow-up, really minimal to no pain walking with a walker. No displacement, doing fantastic. But the IlluminOss gives me the ability to have an intramedullary fixation. It has really expanded what I can do in geriatric crappy bone patients. I need something to make this better. How can I make her bone quality better? 57-year-old woman, multiple hip replacements. The right side's had numerous dislocations, spine fusions. This is her previous surgery. This is before her revision total hip. Unfortunately, there's a domestic violence incident that happens at her home and she gets pushed down. Are we doing a triflange? Are we doing some sort of cup cage combination? Well, she's young. This really helped us recreate anterior column constitution and allowed us to put more conventional implants in a pretty desperate situation for younger patients.
But this is an 81-year-old who lives alone, is actually cleaning his gutters, was up on the roof and fell off the roof with a recent ice storm. So this is a both column with a femoral neck fracture. And so in an 81-year-old, very active, lives alone, cleaning his own gutters kind of guy, there's not a lot of great sort of options for this. And really the implant that I thought of first was IlluminOss. I don't care how active this 81-year-old is, his bone quality is probably not going to be ideal. Initially told him sort of non-weight bearing, protected weight bearing, more so from my standpoint, just because I was scared. But he comes back at 8 weeks and he's walking 2 miles a day. I kind of ask him to come back in, sort of 2-3 months just to check an x-ray. And he looks at me and asks why. And so I said, that's a great question. I have no idea why. You can, I guess, just come back, see me if you need to, buddy. And so he hasn't been back. Those balloons then become stability. Those balloons then become sort of the augmentation that they need.
These people who have terrible bone or osteolysis, it fills things in and makes it a lot simpler. As someone who does a lot of these arthroplasties, it makes life a lot easier. 73-year-old female. She's actually a friend of mine's mother, avid exerciser, walker. She started having pain in her posterior pelvis and she was in a wheelchair. She's been seen by pain management. She's been seen by spine, kind of got run through the whole kind of healthcare system. And then eventually they got an MRI of her pelvis that showed bilateral sacral stress fractures. One of the most undertreated and underrecognized issues that we have in a lot of our elderly folks, especially females. This is her 6 weeks out, and she is just like a maniac. She walks in my neighborhood and the neighborhood across the street. I see her out there all the time. She's back to walking all the time and happy, where she was in a wheelchair for 2 months before we did this. And I think it stiffens up the entire area better. These are fractures of immobility that I think are underappreciated in all of orthopedics. And I think a lot of them are not even treated by orthopedic surgeons because they're non-displaced pelvic fractures and people think they're just going to get better. The older people are getting and the more active they are, we're seeing more and more of these pelvic stress fractures, pelvic ring stress fractures.
They were trained to never fix these, the sacral fractures, specifically the sacral alas. We kind of challenged them to take a look at the patients that we were doing them on. And, we give them all a chance to mobilize first. And after a couple of days, if they're not mobilizing, that's when we start talking to them about this, the response that people were getting and being able to walk out of the hospital. And they backed down and said, we should be doing it. And they've actually started sending them to us.
That's a complete re-education process. You don't even get the consult until like 6 weeks later.
And when they have bed sores.
Yeah, it's complete re-educate. You got to re-educate the ER doctors. You got to re-educate the hospitalists, saying that pelvic fractures in geriatrics, just to say that they're all non-operative is completely an antiquated philosophy.
20 years ago when we trained, it was every geriatric fracture was non-op, weight bears tolerated, too bad, so sad. You're just going to, I mean, obviously 10 years ago, we just did screws, right? And have you all seen the difference with the IlluminOss versus the just screws alone in either pain or mobility, back out, failure?
Yes. Yes. Absolutely. I can tell you, years ago when we would put in, 2 fully threaded cannulated screws with washers. I mean, we've all seen those patients come back into the office with the washer off the bone and floating around in there. You definitely get improved rigidity of the posterior pelvis. You're not relying on purchase. You're not relying on bone quality. You fill the void with something stiff,
I think it just makes biomechanical sense. I mean, this is just a cavernous space when you're talking about the sacral ala. Like, I mean, it's just big, wide open, nothing.